remove all fear from our hearts. Fill us with confidence in your care. And we ask you, Lord, to hear us when we cry out to you and say, Abun Dashmayo, Netqa Dashishmos,
Tise Malkusok Liwe Subyono,
أي كانوا بدشمال أبلان
لحم الإنسان
واشبك لان وحطوين أي كانوا دفعان باقي الحايبين نطلع على الرسول
إلو فاصلان من بيشو تودي لقي مالكوسو حيلو جبحت العالم آمين آمين.
Saudi Sagi, and the floor is yours, Dr. Hasna.
Sayyidna. So now please join me welcoming and thanking our panelists, our Suryoye physician who are working in the front line with COVID patients. They were chosen to answer any questions you have about COVID. I also want to thank them for there is an echo, so I'm sorry. I also want to thank them for their accepting that invitation with a short notice, even though I know some of them on call today, so thank you very much. So we have with us Dr. Rasha Abdel Nasir, who's an infectious disease specialist, Dr. George Vitar, who's an interventional cardiologist, Dr. Aboud Qawwaq, who is an adult pulmonary medicine specialist, and we also have Dr. Yamo Barslibo-Dennis, who is a pediatric allergist and immunologist and has extensive expertise in immunology, research, and drug development over the last 20 years. And my name is Hasna Jalou, and I'm a pediatric pulmonologist and sleep specialist. And we'll start with taking some of the questions. Please send us any questions you have. We'll try our best to get to most of the questions during the time we have. But if we don't answer your question because of the time limit, please feel free to email it to suryoyedoctors@gmail.com. And we'll try our best to reach out to you within 48 hours. I will be checking those emails. So I will start with the first question for Dr. Aboud. Dr. Aboud, when do you think someone is infected with this virus? How do you decide that this patient is actually infectious?
Very good question and a legitimate one, and everybody should know this. First of all, I'd have to thank everybody who made this possible. Without further ado, the issue about being infected has been studied extensively, and we really don't know a lot of information about when somebody is infected 100%, but I can give you some scenarios. There are people who are having that virus and they're asymptomatic, meaning they don't have any symptoms, and they are going around the community and they can spread it without them knowing. And there are people who are pre-symptomatic, like, yes, they're having the disease, but they have not developed symptoms, and those could spread it as well. And then, of course, the symptomatic people. And then what happens later on when you are in advanced disease, you can get to spread the disease, but the shedding will be less because the initial shedding would be more, the viral shedding. And as the disease progresses, it becomes more inflammatory than viral shedding. And therefore, we don't know if the viruses that you're shedding later on in the disease are affecting people and really causing the disease. We don't know. It could be, but we don't know.
Thank you very much, Aboud. And I'm trying actually to share my screen because before starting the session, I would like to give you a quick overview about COVID-19, but I am having some technical difficulties, and maybe Abuna Ogin can help me with that. So I'm not sure why I'm having these difficulties, but sorry for that. And while I'm hopefully fixing this issue, I will try to move on with the questions. So Dr. Rasha, when do you think we should start quarantining if we are infected with the virus? And how long should we quarantine for?
Like Dr. Aboud mentioned, some people, they're actually asymptomatic and they're not having symptoms and they still shed the virus. Now, the shedding of the virus when you're asymptomatic, it's still lower because you're not coughing, you're not sneezing as much, so you should not be spraying as much. So that's why social distancing is still very important. Even if you don't have symptoms, you still want to stay away as much as you can. Limit your going outside if it's not necessary. And when you're outside, try to limit the distance between people for 6 feet. And we'll talk later about general precaution, including the mask, and use it in the public. But once you start having symptoms, let's say you started today not feeling too well, maybe you still don't have fever, you're just not feeling normal, you start with cough or sneeze or runny nose. A lot of people start with dry cough. That's it was the first sign of symptoms. You should be isolating yourself, especially from family.
Thank you very much. I appreciate that. And Dr. Yamo, to go on with what Dr. Aboud said, what are some of the symptoms that people start noticing with this disease?
Yeah, some of the important cardinal symptoms to keep in mind is fever, cough, anosmia or loss of taste, which will be critical symptoms that we all should look for, and seek help with our physician. And I would recommend that you try to get the help without going to the emergency room in case you have the infection, so you don't either expose other people or that you, in case you don't have any of these symptoms due to the flu, for example, so you do not expose others and yourself in an emergency room. Having said that, I am not at the front line anymore, so I will defer to my colleagues who are at the front line to share their perspective on what symptoms and then how to deal with it in a day-to-day basis. So I'll hand it over to either Dr. Aboud or Dr. George Bicard or Rashford.
Can I answer this?
So please.
Can I answer this?
Sure. Yes, sure.
Well,
I'm still having challenges. I'm sorry, getting my talk. So go ahead.
So basically, as they mentioned, those are the cardinal symptoms, which is really the fever. That could be high, could be low, moderate, but usually you get with a high fever, 101 or higher. And that's number one. Number two, you could have the fatigue, the overall fatigue, and that happens as well. And then the most important one that brings people to our attention is shortness of breath. And we're talking about real shortness of breath, meaning that you're unable to finish a sentence sometimes. And that's really severe. And so that's when that happens, people have to seek help by calling their provider and listening for their advice. Usually, as Dr. Yamo mentioned, preferably we can still manage people in the home environment better for everybody. But when it comes to a point where they cannot handle themselves at home and they need help, then going to the ER is the next step.
So finally, I am able, unfortunately, that was supposed to be earlier, but finally I'm able to share the screen. It still is not the mode of display that I would like it to be, but at least I'm able, or maybe, okay, great. So I want to give you a quick overview about COVID-19 and just like to get us speed up to what's going on recently. So what is COVID-19? What is this new virus that we really didn't know much about it approximately like 5 months ago? So this is basically a new virus that emerged from a family of coronaviruses that we've known for years, and it basically can cause the upper respiratory infections, colds. Most people know it as a grippe. and it accounts for approximately 30% of those illnesses. And this is, the name of the virus is SARS-CoV-2. So really SARS-CoV-2 is the virus that is causing the disease, and COVID-19 is the name of the disease that the World Health Organization decided to call it in March of 2020. And as I said, it's well known from the corona family, which the name corona is a Latin word, which means crown, because under the microscope we can see the spikes of the viruses. And this was discovered in December of 2019 and first in China. So as you probably know, there are recent SARS viruses that has emerged from the family of the corona family. And the first one, SARS, in 2002, that is called also severe acute respiratory syndrome, and that was transmitted from pets to civet animals and subsequently to humans. Also, the Middle East respiratory syndrome, that was in 2012 and also transmitted from pets to camels and subsequently to human, and the recent COVID-19 or SARS-CoV-2 that was discovered in 2019, and again we believe is transmitted from bats to Pangolin species and subsequently to human. So unfortunately, this virus so far have affected approximately to 3 million people. This is actually the statistic from Johns Hopkins as of this morning. And as you can see here, we're close to 3 million affected people and close to 200 deaths worldwide. And therefore, as you probably noticed in my previous slide, unfortunately, the case fatality has increased from early April to now from 4.6 to 7%. So as you probably all know already, and we experienced first line, that this virus is a very contagious virus. And why is this virus fairly contagious? Because the rate of spreading the virus is what we call it an exponential growth. So if we look and compare it to influenza, you can see one infected person, according to recent study, can actually affect anywhere from 2 to 6 people. So let's say if we say each one person will infect 3 people, you can see within short period, many people will be infected compared to the influenza that usually will affect, one person will affect anywhere from 1 to 1.3%. So within the same time span, one infected person with influenza will only affect 3 people compared to one person infected with COVID-19 can affect at least 27 people, if not more. So how does the disease transmit? As any other viruses, these viruses cannot really live on its own because they basically dead organism, or some people would like to call it pseudo life organism. So it's transmitted from person to person and most likely via respiratory droplet. However, the jury is still out for possible aerosol transmission or maybe even oral fecal transmission, and we can talk further with our panelists about that. The incubation period, we think it's anywhere from like 2 to 14 days, and the incubation period means how long does it take from the time you are infected until the time you exhibit symptoms. So let's say I am exposed today at the hospital, it may take me anywhere from 2 to 14 days that I will start having any symptoms. So what are some measures we can do to decrease this spreading? So simple things, just like, hand washing, cleaning services, of course, social distancing that we all been practicing for the last couple of months or so. And the purpose of all that really is to flatten the curve so we don't overwhelm our healthcare providers. And as you can see from the slide here, there are a variety of symptoms that people present with, affecting pretty much every organ system. And again, we can talk about these symptoms more specifically with our panelists and discuss further, which we already kind of talked a little bit about it. So who's at risk? So unfortunately, our elderly people are at risk, especially 65 years and older, and more so really 80 years and older. Those who are living in nursing home or long-term facilities, and also anyone with a chronic lung disease, asthma, or really any chronic condition like serious heart conditions, immunocompromised patient, our patients who are on chemotherapy, cancer patient, diabetes mellitus, any renal or liver disease, and of course obesity has like major risk factor for many of things, including this disease, unfortunately, and smoker. So please, I beg you, if you are smoking, maybe this is the time, maybe this is a wake-up call for you to quit smoking, not just for yourself, but also for those who live around you, especially if you have any elderly people or high-risk people in the family. So please think twice about that. So when should you seek medical attention? If you start having any difficulty breathing, any chest pain, tightness, or any unusual symptoms, unfortunately, stroke been reported maybe also with this terrible disease. So new confusion, inability to arouse, any color change in your mouth or face, also please seek medical attention. What are the complications of this disease? There are many, to say the least: pneumonia, acute respiratory distress syndrome, and of course multi-organ failure, and unfortunately, ultimately, death. So what is the treatment? Is there really a treatment for this disease? Unfortunately, we do not have a specific treatment, but what we can do supportive care, symptomatic treatment, and there are some medications and some protocol that our doctor utilize in the hospital. And we can talk further about that with our panelists, and maybe also talking about possibility of vaccine in the near future. And with that, I thank you, and I will stop sharing, and we'll go back to our panelists and continue with the question. Here I would like to check with Dr. Yamo if there are any questions on Zoom that you would like me to address, or you'd like to call it in.
So we are getting some questions here.
Great.
And one question, theme. Can you hear me okay?
Yes.
Yeah. Okay. How does COVID-19 interact with other diseases, and the treatment for it? How do they interact with other medications? For this one, I'd like to see which one of you would like to. It's a loaded question, so maybe we can start with Dr. Bitar.
Sure.
Yeah, Bitar. And start off with you, and then we'll go around.
Well, thank you very much, Yamo and Hasna and Abu Nayo. The thing about it is when patients come in with respiratory problems, they do not necessarily die from that. Most of the death in these patients is really not necessarily the lungs, but rather the heart and the circulation system. And then especially people coming in, let me give you some statistics. A study in New York happened. 1 out of 5 patients who are admitted to the hospital has an injury pattern in their hearts. When we do blood tests on them, there's evidence of heart injury. Those who have evidence of heart injury, that's 1 out of 5 patients. 50% of them will not leave the hospital. The death rate is 50%. While those who do not demonstrate or show evidence of heart damage, that chance of death goes down to 4.5%. That should give you an idea what the deal is. The heart is a major factor in this situation. Now, you ask me about the interaction with other diseases. Well, the thing about it is those who have already had heart trouble, for example, people who have blockage in their heart, or they have other risk factors like high blood pressure, diabetes, and as Hassan was talking about, other risk factors, those, if they happen to have evidence of further heart injury when they come to the hospital, then the chance of death skyrockets. It is those who end up going on a ventilator. And when they end up on the ventilator, 97 out of 100 of them will die. So that is the enormity of the situation we have, and that's why you see differences in statistics in one study to another, to another, to another. Now you argue who is going to have these heart injuries, as I said earlier. If somebody has had, let's say, blockages in their heart in the past, they had what's called angina, or had open heart surgery, or had stents or angioplasty before, these are people who are really top of the list of concerns we have. So to answer your question, to put it very briefly, interaction with other conditions, specifically in this situation, high blood pressure, diabetes, and heart disease in general. Those are really the one that stands the highest. Well, the other way looking at it, these are the people who end up being elderly anyways, above age of 65 in general. Those are the patients who really have this condition to start with, and that's why you see death rate in the elderly is very, very high because of all these risk factors they have. And I hope that answered the question, Yamu and Hasna.
Thank you. Thank you very much, Dr. Bitar. We'll move on to the respiratory. So Dr. Kavak, if you could just add to it as well from your perspective, and then we'll get to Dr. Rasha regarding the infectious disease. Dr. Kavak, if you could go next, please.
Thank you. From the respiratory standpoint, of course, Hasna in her brief mentioned the adult respiratory distress syndrome, which is really a syndrome that we've known for years, that is due to many conditions, the end product of which is ARDS, which is the abbreviation for acute adult respiratory syndrome, which really is severe hypoxemia, lack of oxygen, and that's the key feature of COVID-19, because what happens when you get that into the upper and the lower respiratory tract, then you start having some changes in the parenchyma of the lung. We call it on the X-ray ground glass appearance, which really is changes in the lung that equates and pneumonia changes, if you like, and that could be scattered throughout the lung, mostly to the periphery. And then as the disease progresses, it becomes to the center and it occupies the whole lung. And therefore, you become like with severe lack of oxygen. And as you know, with lack of oxygen, a lot of other systems will fail. And that's where we get into the multi-organ failure. So basically, if you can intervene earlier, and that's what I want to draw attention to people who have the disease in the early stages. We learned from the ARDS population that if we get to prone people, meaning don't keep them on their back and try to turn them to their belly or any other position, that allows them to navigate their lack of oxygen in a better format. As I said earlier on, the disease will not have a uniformity in all the lungs, and therefore you can still navigate more oxygenation if you turn yourself in a different positioning. And actually, I gave this advice to a lot of people at home, where in essence, they manage themselves at home by turning to different positioning in their home environment, which is the best outcome. When they come to the hospital, then we do it in a professional way. And when we put them when they end up needing the ventilator, that's the extreme end of it. And that's when we start practicing what we call permissive hypercapnia, which means we're allowing them to not ventilate heavily. We need them to oxygenate, and therefore we optimize oxygenation with different ventilator strategy that will allow us to do so. I hope that answered that question.
Thank you, Dr. Kavak. Rasha, maybe you could just elaborate a little bit on the interaction of other medications, and also putting on your ID hat, the one medicine that has been mentioned often, and I know study results are out now recommending not to use it, the malaria drug. If you could just elaborate on it, and also the overall interaction, and then I can comment a little bit on some of the latest studies that different companies are doing pertaining new treatment modalities. So Rasha, off to you.
Thank you, Yamo. A few things I wanted to mention in regards to this question. Number one, like you said, the medication. When we first started seeing COVID patients, there were a lot of paper and talk about hydroxychloroquine, or chloroquine, which is one of the malaria drugs. It's been around for many, many years, that it does help with COVID-19. And then there was another European paper came that they mentioned using azithromycin with hydroxychloroquine. Unfortunately, the newer data that we have, that it's not really in favor of the use. So our recent guideline from the IDSA, they don't recommend use it unless it's a part of clinical trial. One big problem with those medications is really side effects and drug interaction. And like Dr. George mentioned, the cardiovascular system get affected with this virus. And those medications known to prolong the QT, which is one of the numbers that we see on EKG, and that can cause some serious arrhythmias, can cause to cardiac arrest sometimes. So that's why we've been using it with caution. The combination, we're trying to stay away from it, especially when people that are on other medication and they're not monitored in the hospital. One other thing I wanted to mention in regards of other diseases, I don't want people to think if you're young, if you're like in your 30s and 40s, then you're not going to get it, or if you get it, it's going to be a regular flu or a regular virus infection, because we're seeing young people in the hospital and we're seeing young people end up on the ventilator. And once you're on the ventilator, we know the mortality rate is higher. The other thing is the most common comorbidities we see is really hypertension and obesity, which it's pretty common in our population. So don't think it's only the rare autoimmune diseases or cancer patient that they're going to die from this. Any people could. So just try to use caution. The last thing I wanted to mention is co-infections, which is we see more in influenza that people, after they get the influenza infection, they can get bacterial infection on the top of it, which can complicate the picture. We haven't seen a lot of data about it in COVID-19, but people, when they're on the ventilator or they're intubated for a long period of time, they still can get bacterial infection on the top of it. So we're kind of erring on the side of caution and treating those anyways when they are sick in the hospital. But we haven't really seen a lot of this reported. Hopefully that answered my question.
Very complete. Hasna, do you want to add anything before I talk a little bit about what is in the pipeline for therapeutics?
No, go ahead. And then there is a question on Facebook, and I would like to take it. It's pediatric. So.
Sure. So in addition to the drug that was mentioned by my esteemed colleague, there is also Remdesivir, which is an antiretroviral that has been tried and has been in the news. Many of you may have read about the potential results, the real results, I should say, will be forthcoming by the company. However, some limited data has been leaked, and I would not pay attention to what that says. I would rather we wait until the company has done all of their analyses so we can better understand the data. So that has given hope for many people who happen to be either in the intensive care unit treated by Dr. Kavak or Dr. Bitar for the very, very ill patients. Additionally, there are two what we call IL-6, interleukin-6 inhibitors that have been on the marketplace and approved for rheumatoid arthritis. One of them is named Actemra by Chugai, a Japanese company, or Roche in Europe. They market it for moderate to severe rheumatoid arthritis. And the other one is Kevzara, which is another anti-IL-6. That one is run by the company I work for, Regeneron. Those companies have undertaken, in a very short period of time, big investments to get the right studies done. And we have worked extensively with the NIH as well as with the FDA to make sure that we design the appropriate studies, and the best studies for this type of medication is to do the gold standard, which is called double-blind placebo-controlled. It's a fancy name for saying that the drug is given in a blinded fashion, so the doctor doesn't know and the patient patient doesn't know. And the results observed, or the best results that many health authorities use in order to then make a determination. Unlike the hydrochloroquine studies, which were all one-case studies here and there, these are really well-designed studies. And I hope that those studies will come out in the next several months and will give us hope on whether or not for the severely ill patient, there is a treatment that our physicians can use in the front line. And then last but not least, equally important, we also have developed a specific antibody for COVID-19 or this coronavirus, and that will take about 6-7 months to get the results of. So there is hope out there, despite all of the news that are out there. And then last but not least, which is the most important thing that we're going to need and will take us about 12 to 18 more months, is the vaccine. And we will talk more about the progress that is being made even there by the biotech companies, by the governments working together so that we can have a vaccine hopefully by next year, just like the flu vaccine you would get, it would be combined with it, and hopefully it will offer the protection. And we'll talk a little bit about testing on what protection means, etc., moving forward. So with that, I'm going to hand it back to Hasna to take the next question.
Thank you, Yamu, Dr. Yamu. So I actually want to just go briefly back to Dr. George and ask him, given what we heard so far about chloroquine or hydrochloroquine, have you experienced firsthand any patients who came to you and they took the medication and have any complication like Rasha mentioned, maybe arrhythmias or a prolonged QT syndrome or what have you?
That's a very good question. In fact, the first mortality, the first case of death in our town was somewhat confusing, where the patient was given this medicine and they were having these arrhythmias. And at that time, people were not talking much about it, but we've seen these arrhythmias, and patient was having where the heart rhythm was kind of erratic and the heart becomes irritable and speeding almost 200 beats per minute, where the bottom chambers were acting on their own, if you will, and the patient collapses, and you do the resuscitation, and it's all at the end, patient dies. So it becomes confusing whether the heart on its own was going through this process, or is the medicine exacerbated this problem. But there are so many other studies that were done showing that definitely this medicine does affect the electrical conduction of the heart, which we call the QT interval, which is a measure of conduction through the heart muscle in a way. And we know definitely that these medicines do affect that duration, and these people who have this condition are known, even without this crisis of COVID. Whenever we see that abnormality on the cardiogram, that's a red flag for us. So therefore, what the point about that is, for those patients who are taking this medicine, I believe they should check with their doctors and make sure it's safe for them to take these medicines. If a person already has abnormalities on their cardiogram, they should be extremely careful. And I would not recommend taking this medicine at home for anyone, unless they're supervised by a physician, or preferably in the monitoring situation where we monitor this heart rhythm, which will be the early sign that disaster is about to happen. And I've heard a lot of people, in fact, even from our community, who are taking this medicine prophylactically, if you will. I do not know how they got it, who prescribed it to them, but nevertheless, they take this medicine with the hope that it will prevent the disease from happening without realizing that this medicine has this effect. I would like to add one more thing, which is pertaining to our community. There is some data, and Hasna and Young will probably know better than me on this situation. In the Middle East, we do have a genetic disorder called G6PD, which is very common, by the way, in Syria, very common. And those patients who take medicines like this are very prone to having major issues with it. And so even though that kind of somewhat questionable, but there's something to that. I would be extremely careful, especially in our community where we are more susceptible to these potential side effects.
May I add on something, please?
Sure, please.
To add to what Dr. George has just said, really what we noticed now, and you can see that in the literature, we deal in different hospital setting with a different protocol. Each hospital has their own protocol for treatment. And we have realized now with some observational studies that protocols do matter as far as the side effect. So we need to pay more attention to what else we're giving those people beside all those medications like the hydrochloroquine or the remdesivir or so on. Because really the interaction between the different medications could cause complication beyond the actual disease, and we have to be aware of those facts. Add to it, I was going to add another point here about ventilation. The talk was heavily in the early days of COVID-19 that everybody is running out of ventilators, and realizing in the critical care community that we really don't need to jump to put people on ventilator right away. We can manage them with a lot of help without needing the ventilator. The safest way, everybody was afraid of doing the high flow oxygen and or via a technique called non-invasive ventilation because it might spread the viral in the atmosphere of the room. But nowadays we can use safely something called CPAP, which most sleep apnea people use, and that could avoid intubation a lot of time. And really nowadays we're trying our best not to intubate everybody if we can. Thank you.
Toby for that. And I want to acknowledge Maria who asked that very insightful question regarding COVID-19 interaction with other diseases and medications. Next, I'd like to move to Mr. Pierre Aydin's question. Can the panel talk about how the virus gets transmitted and then also infects others? Is it only via droplets? This is a very important general medicine question, but needless to say, critical for how we interact and minimize the infection rate. So, Rasha, could you please address that?
Sure, we'll be happy to. That's one actually of the topic I really wanted to talk about because people are afraid and they're not sure what to do. And I notice people when I'm walking, like I'm buying stuff or I'm in the shopping place, how they use the mask, and there's a lot of misuse. And that actually sometimes causes more harm than good. One thing about the transmission is we know it goes by droplets. So people, let's say I'm carrying the virus, if I cough or I sneeze, so droplets going to be in the air. It's not similar to when you are in the hospital getting intubation or using or having any airless procedures. This is when we talk about the airborne, and I know there's a lot of panic in the community about is it airless, is it going to stay in the air for a long time? We don't expect that's going to happen when people are in the without having any of those invasive procedures. We still think it's droplets. Transmission is the main thing. The highest amount of the PCR virus is in the respiratory secretions, but we've seen it based on data reported recently that we see PCR from the stool. But oral stool transmission hasn't been reported. But that's one thing. We know people shed their virus in the stool, so you have to be cautious if, let's say, somebody's sick in the hospital and they have diarrhea, they need to handle that in a sterile way. The other important part about transmission is really those surface contamination. So people, when they cough, they sneeze, let's say you cover your mouth with your hands and then you touch the surfaces. And that's, I feel it's the main issue when you're out in the community because in general, people not always careful. So if you cough and sneeze, instead of covering your face with your hand, it's better to use the elbow. So then you're not touching the surfaces with your contaminated hands. The other thing that's very important is to use mask in the community, and that's why we're moving toward using the mask. And it's not because you're trying to protect yourself, it's trying to protect other people, because the mask, it will protect other people when you cough or sneeze. It will handle that droplet and keep it safe. The other thing it should be doing is help you hopefully prevent you from touching your face. So one common thing I've seen out in the community, when you put the mask, you should not be touching that mask with your hands, and you should not be moving it around your face either, because then you're going to contaminate your hand, and then you touch your face, and you touch your mouth, and then you're going to have the virus on your face, which that's the one part we want to avoid.
Thank you, Rasha. Thank you for that. Next, we got a question from folks on Facebook. And the question is, talk a little bit about pediatrics. How susceptible are children to this infection? Maybe Hasna, if I could ask you to put on your pediatrician hat on.
Yes, sure. So fortunately, children are not very affected with the disease, and we really don't understand that very well. So there are specific receptors that the virus actually affects us, all of us, called ACE2 receptors that people thinks one of the theory is maybe they're not well developed in children, and therefore children are not affected, saying that it works just like any other risk factors. So unfortunately, we are seeing children from infancy to adolescent with this disease. We unfortunately have 6 kids now in the hospital, ranging from 10 months to 17 years of age. They on the respirator. So risk factor, obesity, secondhand smoking, or of course some of the adolescents who smoke too, or any other chronic condition. So our patients who are trach, meaning they have tracheostomies, tube in their throat to breathe, or they have sleep apnea or severe asthma, the same risk at any other adult. However, I would like to turn it back to you, Yamo, and talk about the immunology point of view, because we know this is a new virus. Our immune system doesn't recognize such a virus because we've never been affected by it. So what are your thoughts on that?
Sure, yeah, thank you. So I just want to qualify it. It depends on how young the child is. As many of you, immunologically, the children up to the first 6 months will have received the immunoglobulins to protect them from the mother. And then beyond that, they are really, if they have not developed their own immune defenses, they can be at high risk, and those are the ones that would probably suffer most. But having said that, with an intact immune system, thank God the children are resilient and are able to fight this. With any novel virus or bacterial infection, the body has an unbelievable way of fighting and adapting. And what happens is immunoglobulins, you will have read or heard on TV, immunoglobulin M and immunoglobulin G. These are proteins that the cells make in order to identify a virus and then be able to map it so it can get appropriately attacked by cells in our immune system called macrophages in order to isolate and then kill either the virus or the bacteria. And this is what is also being used either for a treatment or, as we will develop, either the vaccine or the testing that we said we would talk about as well. So thank God children are not as eagerly infected by this, but it depends on how old they are. Having said that, we need to make sure that we always protect the children and ensure that if they develop any of the symptoms you highlighted or Dr. Aboud highlighted initially, that we pay attention to those, because they too can get sick very, very quickly. Can I move on to the next question, or do you have anything else to add, anybody?
I have just another question from Facebook, if I may. So we have a question that probably I'll address it to Dr. Rasha. Is there any factual study on how COVID-19 affect pregnancies or breastfeeding?
Yeah. Of course, being pregnant or having a new baby, it's an extra anxiety for people. So I know people are anxious about it more than the general population. Fortunately, we haven't seen any study that said actually pregnant women are sicker than the general population with this virus, like we have seen before with influenza. We know influenza can affect the pregnant women worse or more severe cases than non-pregnant women. But in COVID-19, we haven't seen any of those yet. But again, we don't have a lot of paper about pregnancy. But we know that pregnancy in general does affect your immune system and alter your response to infection. So I'll be extra cautious when I'm pregnant. I'll take extra precaution and make sure I'm following the social distancing, hand hygiene, staying away from sick people as much as possible. The good news is when they check the PCR for virus and the uterus or in the amniotic fluid in the vaginal area, they couldn't find the PCR there. So we know there is no transmission from the person if a pregnant woman get infected to the baby when they are inside. There is cases reported about newborn got the infection after delivery, but they think that was from exposure after delivery, not during the delivery or while they were inside the uterus. In regards of breastfeeding, the same thing. There's no PCR detected for the virus in the breast milk, so it's still safe to breastfeed if you're breastfeeding, but you have to take extra precaution, of course, not to have the virus transmitted from you to the baby. So what they recommend is, of course, hand hygiene as much as you can, put mask and then pump the breast milk and give it to somebody else to feed the baby if possible in the time when you are sick and having the COVID-19, but you still can breastfeed your baby, which is a blessing.
Yes.
Good. Okay, next. This one everybody will like, so I want to thank Stephanie Kavak for it. She has a few questions for us here. And this one, Dr. Bittar, I'm going to target it for you. Her question is, can you help address claims made on the treatment of COVID-19? One, there is an old wives' tale claiming that drinking arak may help kill the virus. I'm wondering if those people listen to one of Trump's press conferences. Don't give him any ideas about that, please. Second is, could you please discuss on this claim and why it may be inaccurate to drink arak? So, Dr. Bittar, if you could please address that.
Well, I think as far as arak is concerned, I think Aboud would be a better answer for that question, but I would. I cannot answer the question to start with, but I think the point is, in my opinion, that is, the virus surface is full of fat tissue. I mean, it's lipoproteins, a lot of lipids, and certainly alcohol. That's how I think, and I think the other panelists will probably jump on that too. That's how I see, yes, it can kill as an alcohol, it can kill that virus basically itself. But the thing about it is, how can you get the alcohol to go to the lungs? If you can figure out a way of doing it, good luck to you. So maybe inhale it.
No, please.
So, as far as the, why not, I'm taking scientifically, let me be very serious about this. People are asking that question. There is no study, and people are talking about it. I think I would rather than swallowing the arak, I would like wash my hands with it. Maybe that's a better option. I think that's probably give you better results. I mean, that's how I see it.
Yeah. Aboud, do you want to chip in here?
Well, I want to chip in, but I want to remind you about a prior comment about pediatrics. Even though they're having it easy as the disease evolves with them, but they are the transporter of it. They have to be aware in our community that don't be as courageous saying, oh, it's not going to cause anything to me and cause harm to your own family. Be aware of that fact. That's very important. Okay? And as far as the arak, I have no comment.
Okay.
Don't drink.
Yeah. So no smoking, no drinking. It will not help with COVID-19. The second question from Stephanie is for all the panelists. And Rasha, I'll point it to you. Could you please discuss using vitamin C and zinc as a modality to prevent COVID-19?
There's a lot of the over-the-counter stuff that has been mentioned, including vitamin C, zinc. There's actually one of the trials they want to try to do with vitamin D as well. There's mention about melatonin. We don't have any data to prove that it will help or not. If you want to take it within the therapeutic range, don't overtake those vitamins, that's fine, but we don't have any data to prove that it will be a preventative. So I'll still follow the normal and the general guidelines about social distancing, hand hygiene. That will be the most preventable measure you could take.
Okay, thank you. Anyone else wants to add to the vitamin question?
A point about zinc, because everybody talks about it now and everybody swears by it. However, there was only in the literature an observational study about zinc in the treatment of rhinoviruses. You can take it earlier in the disease within a day or two from the beginning of symptoms and make a difference in shortening the disease. But nobody mentioned in that observational study that it is really as prophylaxis or preventative. Thank you.
George, do you want to add anything on vitamins?
Not necessarily, not much more than what's said, but again, everyone comes out with some different ideas, but the whole point about it is for these vitamins, and vitamin C, I can add it to the list. I mean, this can be what's called an antioxidant, and supposedly the disease, as the virus comes in, the virus itself does not necessarily kill people, and as you yourself will kind of elaborate on that, where the immune system is messed up and we have an inflammation, and maybe through that, for the anti-inflammatory effect, could have an effect. Again, all this is theoretical thing. There are other drugs. Speaking of the same thing, colchicine that we use in the Middle East, that's for our community also. We have what's called familial Mediterranean fever. We use that medicine as an anti-inflammatory drug. There are studies about it. But for me to stand here and tell you there is benefit, the answer is no, no one knows.
Okay. Toby, for that, all of you. I'm going to move on to the next question because it also opens the door for us to talk a little bit about testing itself. So this question I'm going to give to Abud from Sarapaho. My son, who's 9 years old, had a dry cough back in October. He had a wheeze associated with it and was put on a nebulizer for the first time. Could that have been COVID-19? The pediatrician didn't know what was going on. So, Hasna, after Abud gets the chance, if you could also address it, and then I'll put on my pediatric hat as well to try to link it to what testing we could do in circumstances like this. So, Abud, do you want to comment on that, please?
Yes, I can. Thank you. Basically, what she's telling us, the symptoms started in October of last year. Nobody at that point would know anything about COVID, so we don't know. And we don't know the details about what happened around him. Was he exposed to anything, travel history, anything like this? A 9-year-old with this kind of a cough and wheeze, let's think about other diagnoses. How about asthma? How about any other condition? But don't jump to that conclusion right away. There is not enough symptoms to suggest to me that we're dealing with it.
Yeah, Hasna?
Oh, sorry. I agree with Abu. So in October, unless he really traveled to China or anywhere else in the world, it shouldn't be COVID-19, hopefully not. And as most of you probably know, usually viruses are common in the fall, and that's when we see a spike in our kids presenting with a new onset asthma, or it could be a typical pneumonia that can cause wheezing. I need to know more about the patient, and I'll be more than happy if she want to reach out to us through Suryoye doctors@gmail.com to answer her question, because I need to know family history, his prior symptoms in the previous years and what have you. One thing I would like to comment on, is hopefully he's doing well now and he doesn't need the nebulizer, but just be careful. Nebulizer are not recommended at this time. So I'm switching all my patients to MDI. So just a puffer, we call it MDI, puffer inhaler with a spacer instead of the nebulizer, because as we mentioned earlier, Dr. Rasha, that the virus is mostly droplets, so we don't want any droplets in the airs. So please be careful with that. Also, anyone who's on CPAP, on BiPAP, they really should be very careful with that, and do not move your machine from your room, or don't let anyone else come to your room, especially, hopefully you won't have any symptoms if you have any symptoms, okay? That's about it. I don't know what your thoughts on that, Yamu.
Yeah, I have nothing more to add except to remind everybody common things happen most commonly, and I think Dr. Kawak and you have highlighted very clearly what else we need to keep in mind in this instance for your 9-year-old. But that opens the question then. When do we, as physicians, as parents, say, I should have testing done? So let's pick a 19, 20-year-old and a 65-year-old. And I'll start off with you, Aboud, in terms of what type of symptoms would you need to see through your telemedicine in discussing it with the patient to say, you know what, we need to get you tested. And then what would you be looking for, and why would you be testing? What triggers that thinking in you?
Very good question. Basically, every institution now has created a questionnaire for people who are coming to their attention to verify the high likelihood of them having a possibility that COVID-19 diagnosis. Number one is we need to know about their age, their other conditions. And number two is the travel history. Number three is contact with other people who are sick. And then we come to their symptoms. If they're telling us we have fever that we could not explain otherwise, and then we have some lack of taste, as you mentioned earlier, and or body aches, and we're talking about starting to have more shortness of breath, then those people have to be evaluated further, and testing would be the first order of business.
Okay.
We have actually many more questions from Facebook, if I can address those, so we don't ignore our people on Facebook, and appreciate all of you who are with us. So I have a question from a dentist. He's asking, I think it's Dr. Samer Ato, and he's asking, being a dentist, ordered to stop working, if we will go back to work, what recommendation you can give us? Rasha, maybe?
Yeah.
A bit more infection.
Sure, yeah. The general recommendation now for dentists, if they want to, because we know when they try to work in the mouth and they're trying to do procedure, there's a risk for aerolization, which means it's not only the droplet, it's airborne, which is it can stay in the air for a longer period of time. And the other thing is there's other people in the office that are at risk to get the infection if they're having the infection. So we still have dentists in our hospital practicing just for emergencies, but what the requirement is, it's in ideal situation is to have an airborne room, negative pressure room. But if they don't have that, they should have a room with a door that they can close. And the dentist and whoever is helping them, they should be wearing an N95 mask with a face shield. So they should be covering their eyes and they're covering their mouth with the N95 mask because of that risk of aerosolization. And they should not use the same room for the second patient afterwards. They have to do the deep cleaning with wearing the N95 mask as well. As far as I know, they're not allowing the dentist to open again yet. But whenever they have to practice for emergencies, that's the requirement.
Thank you, Rasha.
Dr. Bittar, do you want to add to that?
Not really, not more than that, but I think the concern I have is when you talk about patients symptomatic and asymptomatic, recently found evidence, and I think our community needs to be made aware of, which is not really related to the question you asked, but I think it's important for the sake of time that this can be brought up. There are a lot of patients, especially young people in their 30s and 40s, who have very mild disease and who are staying at home and end up having strokes from this disease. This is very much, nobody talks much about stroke in this situation. Mm-hmm. The disease causes clotting of the blood in the systems, both in the arteries and veins. And the reason I bring this up is because people are afraid of calling the hospital or contacting or going to the hospital for the fear of getting the disease from there. They think the disease resides or lives in the hospital. And their symptoms are not that sick. They don't have much cough. Their fever is very minimal and they're staying at home. Yet they have a major stroke. The reason for the urgency of this situation is people who have stroke or even heart attack, we can take care of them if they come into the hospital within certain time, preferably in the first few hours. Delaying that, we were basically missing out on the whole thing. And that concerns me. So if a person has any symptoms, something we call the FAST, F-A-S-T, and I would like to everybody kind of pay attention to that. If you have your face drooling or facial droop for no reason, if you start to have your arm weakness or leg weakness or what have you, that you cannot function normally, or if your speech becomes slurred, do not wait on this. This could be part of the issue we have. And additionally, what happened with COVID, the blood clot very, very fast, especially if this is noticed in people who are on dialysis, which is the worst thing to do. The blood keeps clotting in the tubing for the dialysis for no reason, or we don't know the reason. It could be the inflammation that you mentioned and Dr. Abud mentioned. So we need to act quickly. We can do something. We can go in and retrieve the clots from the carotid arteries, the arteries that go to the brain, and even in the heart, if you will. So I think just to bring it to the attention of our community, do not get frightened by going to the hospital when you need the hospital. And after all, call your doctor, stay in contact with them. So I think just these measures to make sure, do not be scared of going to the hospital if you have an emergency. And thank you.
Toby, George, Toby, Sagi, two very quick questions. Does high temperature have any impact in killing the virus? One. And the second one, if somebody already had the virus, or they less likely to get it a second time, and then this person, K. Taschi, I believe, she says, or he, I heard that oregano oil is a good replacement to antibiotics. So, Rasha, maybe you could just address the question of if you've been infected once, what are you at risk of getting it again from an infectious disease? I will give my immune system expertise answer to that as well. And then temperature-wise, Abud, if you could maybe address that. So, Rasha, off to you.
Sure. The short answer, we don't know yet if somebody had the virus, if he can have it again or not. We know they develop antibodies after the infection, but the main question is we don't know how long those antibodies is going to be in the system. So the short answer, we don't know. I don't expect you're going to have it in the following month, but we don't know how long you're going to be immune to it.
Toby, so immunologically, I agree with that. That's why I took the opportunity to mention these two specific immune globulins that we usually develop, which is innate to our how we fight any type of infections, new or old, things that we've been exposed to. If you have developed, when the testing is done, and you show that you have what is called immunoglobulin M, that is the initial response, and then if you've developed the cells that now make immunoglobulin G, those are the ones that will protect you for a longer period of time. And then how that interaction takes place and whether or not those memory plasma cells have already made it, and how they divided, etc., depends, and I think it's at its infancy in our understanding for whether or not you're at risk of redeveloping it a second time. I would say that it's less likely, but it can happen. Abdul, with respect to the temperature, if you could please elaborate on that.
Yeah, I would love to, but before I say that, let me mention one point about the reinfection. Possibilities are even different here. I'll bring two scenarios. You have to remember the test being positive has at least 20 or 30% false negative. So it's possible that you tested somebody and he was negative, but he was not negative, he was positive, but we didn't know it. Number one. Number two, the virus itself, there are some studies mentioning that it changes itself. Some of the nucleic acid changes in that particular virus, and suddenly it's a new virus for that human host, and therefore it's a new infection by somewhat a newer virus. Those are the speculations about it, besides what you mentioned for the immune system. As far as the temperature, are you talking about temperature in the environment? Like,
yeah.
Well, everybody talks about it, and everybody is hoping that as the summer comes in, we will have a less of an impact from this illness. But let me draw your attention to other part of the world where it's really hot no matter what, and we still have illnesses, we still have disease. So yes, it's a factor as far as the environment is concerned, because the virus itself is not going to survive on hot surfaces for a long time, but still you can get infected in hot environment.
Mm-hmm. How about oregano oil? We don't want to forget that. That as a good replacement to antibiotic. Hasna, do you want to address that?
I don't think so. I don't think so. You guys have to be careful, and I believe those are expensive oils. I mean, essential oils and other oils. I would say you really need to consult with your doctor. You also need to know where you're buying this oils, and to make sure. I mean, we've seen, unfortunately, sad cases in patients with liver failure needing transplant who are taking this supplement overseas. I mean, they get it overseas, on the net. So please be careful with that. Do not use anything. I think, if I may, while I'm addressing this, go to the point about the vitamins and others. So you don't necessarily have to take vitamins. Probably you all hear me talk about that. The 3 pillars for a good health and hopefully to stay healthy and fight any illnesses or infection is to eat healthy, to exercise, and to sleep well. So if you do those 3 things, you don't need to take vitamin C, but you can eat an orange a day. You can eat your fruits and veggies, eat healthy, stay away from, carbs if possible. We all love those, and that's my comment on that. If I may go to Dr. George for follow-up on these questions also. So with fever and reinfections and what have you, so what are the long-term effects of COVID-19 after we recover? So let's say I was infected and now I feel fine, do I have any major sequelae, and does it really matter if you have mild, moderate versus severe disease? Please, if you can elaborate on that.
Thanks for asking this question, Hassan. This is a very important question. Number one is the disease has been around for 4 months, as far as we know. So the patients who have kind of recovered from disease are still in the early phases of their recovery. But from what we know, there are a lot of things are on their way. For example, let's say I will take it system by system. The heart, when the heart gets damaged, when there's some heart injury, that's not going to go unnoticed. The heart will become very weak, and a condition we call cardiomyopathy. Some people end up having what's called congestive heart failure. They can have arrhythmias and things like that. Luckily, we have some medicines for those, but that's one situation that we have to deal on the long term. On the lungs, and of course, Aboud is in a better position to answer that point, but I believe as a result of the inflammation that's taking place in the lungs, scar tissue forms, what we call fibrosis, scar tissue forms, and that's not going to go away right away. It takes months and years, and I'm sure you know that as well. So those are long-term sequelae of the problem. And thirdly, the patients who have this condition, as I said, people have had strokes. The problem with them in the hospital, any patient who had stroke, they have physical therapy and rehab. Unfortunately for these patients with COVID, they are not as fortunate to have that kind of management. But in isolation, they're locked up in their room. So they have a long-term problem from rehabilitation. Being embedded in the ICU, locked up for many, many days or weeks, they lose their muscle strength and they come out very, very frail and weak without any rehab or physical therapy. Add to it also, which is a major, major thing actually that nobody talks about, is the psychological impact. The psychology, that's what's happening. When a patient comes to the emergency room, that's probably the last time that that patient will see his family. As they end up in the hospital, they're isolated. They're locked behind closed doors. Nobody comes to them. Nobody talks to them. Maybe luckily if they have a cell phone or something. Imagine being in that situation. Speaking of that, I honestly recommend maybe on a later program or something, we ask one from our community, a psychologist or psychiatrist, to address these needs that nobody talks about. It's not just for the patients, but also for their loved ones, those who deal with them, for physicians, for healthcare providers. So all of these are the long-term, we just don't know. Whatever we know is from based on the prior SARS disease or MERS disease and things like that, and how much damage they left behind them. So I think that we are in the early stages of the problem, and we will see how it goes.
Let me
Thank you, George, for that. Yes, Aboud, you want to add?
Yeah, as George mentioned, the pulmonary complication, which is really the most important one, is that everybody talks about it, the adult respiratory distress syndrome, ARDS. We know from other ARDS related, not to COVID, that there would be a long-term consequences for people who survive this end lung complication. Usually they get fibrosis, meaning they have scar tissue of the lung, and they end up maybe at some point needing oxygen for life and curtailed in their activity because of that pulmonary fibrosis that would sink in. However, we noticed with the ARDS related to COVID, you have two dichotomy here. You either recover completely or you die. And most likely the recovery, actually, the good news, the death is not as immense here. So far in the last 4 months, as George mentioned, we have not noticed from those who recovered, from the pulmonary standpoint, they had any sequelae as they recovered. Thank you.
Toby, I'm just going to do a time check. Goal is, so we have another 6 minutes until it's 1:25, and then we need to wrap up and hand it over to Abu Hasio. I have one question that Hasna kindly forwarded to me from Pete Cards, and this is for Russia. Once someone who had the virus is cured, could they still be contagious right after? And then could someone get COVID-19 again? If you could address that, that would be great. And then we can have other of the panel add to it.
Sure. I'm assuming you mean that the symptoms did resolve. We know that the virus has been detected in the respiratory secretion and in stool up to 28 days after the virus has affected the person. But we're not sure if those PCR are actually their dead virus or their live virus. We know when they're symptomatic, and pre-symptomatic is the highest risk of infecting other people, but we know that they can shed the virus a longer period of time. But what we're making, for example, people who work in the hospital, if they got an infection, after 2 weeks, they should be okay to go back to work. We're doing the mask just to protect the other people from the secretion. But we don't know if they are infectious after the 2 weeks or after they resolve the symptoms, but we know they have the virus in their respiratory secretion and in their stool, but we believe that it's not as infectious as it is when they have symptoms. The second question, which we already kind of talked about, the reinfection. We don't know if people are going to get reinfected because we don't know if the immunoglobulins, how long they're going to stay in the body or not. But we're talking, of course, about confirmed people. So somebody who had the confirmed test and we know they have it, they're less likely to have it again soon. But like Dr. Aboud said, the virus mutates, so that's a possibility. We don't know still everything about this virus, so I will still cautious. If I have it, it doesn't mean that I'm immune and I can go out in the public and do whatever I want and I'm not going to get the infection again. I'll still be cautious about it. One last point I wanted to mention about the temperature, not the environment temperature, but one thing for people who are caring for sick patients, or if you work in a place when you have a high risk to get your clothes or your material contaminated with a virus, actually high temperature when you put your load or your in your washing machine or the dryer can kill the virus. So we recommend that you put the washing machine on a high temperature if you're washing the clothes of a sick person or you have risk for exposure. And you can put it with other people's clothes, but you just have to put it on high temperature and put as well the dryer on high temperature.
Thank you, Rasha. Dr. Aboud Kawak or George or Hasna, do you guys have anything else to add?
Well, let me bring the attention of everybody to what the CDC has recommended for the issue of after you recover, what happens. The recommendations are really placed here in two categories. You can have the test-related strategy or the non-test strategy. Test strategy meaning you're waiting for somebody to have no resolution of all the symptoms, basically no fever without the use of any anti-fever medication, no shortness of breath, none of the symptoms that started the illness have disappeared completely, and now you're testing them, again the PCR testing, twice within 24 hours, meaning you have to have 2 negative tests to then let them free in the community. That's the testing strategy. The non-testing strategy, you can have at least 3 days of no symptoms from the recovery time, meaning no fever, no shortness of breath, no body aches, none of the symptoms started, and or you have 7 days from the starting of the illness. That's the recommendation of the CDC.
Okay, George, anything to add?
Now, how much time do we have?
We literally 2 more minutes, and then I need to wrap it up and give it to Abu Hasya to conclude with the prayer.
Yeah, not much more to add in that situation, but I would say, to summarize it, at the present time, we do not have any treatment for this disease. I'm hard pressed by any information we have, every medicine we have. There is no medication to treat this condition. It's kind of amazing to me, surprises me or surprise everyone, I would say. We are able to put a man on the moon 50 years ago, but a little tiny microbe we have not been able to handle. And also I would like to add one more thing is that we are not going to get rid of this disease anywhere on the face of Earth unless we clear it everywhere on the face of Earth. So you cannot leave this virus anywhere. In order to get rid of it, to stop this epidemic, it has to be stopped everywhere on the face of Earth. So, and as far as the virus is concerned, which I know a lot of people are kind of putting too much hope on it, and that's at least a year to 2 years away. But again, how about, that is if we're lucky, but how about if we're not lucky by getting this vaccine? What will happen then? I think precautions are the most important. This virus cannot move, cannot walk, does not travel on its own. People are the one who moves it and gives it from one place to another. So I think we have to go back to the basics, as Rasha and Abud has said earlier. Precaution, social distancing, washing hands, all the hygiene things that we talked about. So I will leave it at that.
Toby, Sagi. Hasna, before I conclude and hand it over, anything else from you?
No, but I was wondering if, no, thank you, actually.
No? Okay. So I do want to say, Toby Sagi, before handing it over to Abu Hassia, to this esteemed panel of experts. It's just the beginning of the discussion. Also want to recognize Abu Bayroyo Aljin for the technical abilities. I will start calling him the Bill Gates of the Suryoye for enabling this. Most importantly, I think, George, here is where I want to maybe add a few sentences, but put it into historic perspective. Let's not forget, 1918, the Spanish flu, everybody talks about it. Half of the population of the world was infected, and we lost anywhere from 50 to 75 million people. This is no different, but if we look at the mortality, etc., I am actually very optimistic. I think if ever there was a time for us as a human species, we would be ready to take on a pandemic as bad as this one. This is the time when molecular biology, when our understanding of medicine, when our ability to utilize all of the tools out there, and then despite the globalization that exists, the traveling, when I look at the number of people infected and what it could have been, I'm actually very optimistic. Being also by nature a research and development guy and spending 24/7 on looking at how we can best develop medicines, I am very optimistic that within the next several months, we will have the readout from currently already approved, FDA approved, such as the two Actemra and also Kevzara. Additionally, our monoclonal antibody, and I'm also, as an immunologist, very, very optimistic that the progress we are making on vaccine development, I think, will open up a new chapter for how we work together with World Health Organization, United Nations, et cetera, et cetera. So while it is hectic times for everybody, I mean, many of us have never celebrated Easter, Eid al-Rabo, with Todi to Abu Hasio, and also Qumran, Abu Fatriarcho, looking at it and utilizing the technology. While things are hectic, there is a light out there, and I think the worst is behind us. I am very confident that we will have the developments available, and that stay tuned. I hope that we will have other opportunities to be of service to our beloved Suryoye community, not only in the U.S. but everywhere. And I want to thank specifically Hasna for pulling this panel and helping us all get together under Abu Hassio's direction to be of service for everybody. So with that, I'll hand it over to Abu Hassio for a prayer and anything else you want to say, Abu Hassio. Can you unmute Abu Hassio?
Yes.
Just
Tawdi Yamo, Tawdi to all of you. And just my niece Stephanie was asking me, what are you going to do when the country will reopen? Are you going to reopen churches and abide by the CDC regulations? Of course. And I was really yesterday talking to my friend Jack Hennawi from the AEC Council, talking about, and we are going to have soon, hopefully next week, a meeting with all our parish council presidents and clergy to talk about reopening. Of course, we are not going to do anything unless we have the permission to do it, because I really do care about the health of each and every one of you. It wasn't easy on me and on all the clergy to celebrate without you, but as I mentioned many times, you were always in my heart and in the heart of all the clergy. We love you dearly, and we will try to do the best to connect and to bring the church to your homes, and this is what we are trying to do. And now I would love to close with a prayer. Almighty Lord, thank you that you have revealed your love to us during this educational session or event. We invite you, Lord, to send us out from here in the power of the Holy Spirit, and we ask you to reveal your grace and truth to us each day during our life. We ask you finally to bless all of us, to bless our churches, to bless all our organizations, and give us the strength to continue working for your glory and kingdom. For yours is the kingdom, the power, and the glory forever and ever. Amen. Taudi, and may the Lord bless all of you.
Thank you, Sayyidina.
Thank you.
Thank you.
Taudi Abu Hasio.
Taudi. Bye-bye.
Bye-bye.
قم من ذكرهم يوم النور